Hi, my name is Caitlin Fortenberry. The QI project that I chose to elaborate on was for healthcare associated infections, specifically in the surgical ICU that I work at in North Oaks Hospital. So, healthcare associated infections are occurring at an unacceptable rate in my surgical ICU. It yielded an increased risk of mortality, potentially increasing the length of hospital stay, increasing the risk of cost to the hospital also. So, the Centers for Disease and Control and Prevention estimated that there was about 1.7 million HAIs and 99,000 healthcare associated deaths in the United States annually, which is a drastic number. Our SICU's recent quarterly numbers prove that our HAI scores doubled with the infections of central line associated blood infections, CAUTIs, which are the catheter associated urinary tract infections, the VAPs, which is the ventilator associated pneumonias, surgical site infections, which that is a huge deal for us because we get a lot of surgical patients, and C. diff infections. There was also a citation found that there was an average cost per HAI ranges from $15,000 to $40,000, with severe infections costing over $100,000 per case. And that number is what the hospital would pay. So there's an increased amount due from the hospital because of these preventable infections. So, furthering research into why our HAIs have doubled over the last quarter, I found that the root cause analysis for these were the inadequate education programs and inconsistent policy communication throughout the nursing staff and the hospital, insufficient leadership prioritization, and infection control initiatives. The lack of systemic approach to a continuous quality improvement was also found. The secondary causes were the implementation of infection prevention protocols, insufficient resources and oversight for infection control measures, and a higher staff turnover, which has led to communication barriers and outdated procedures and protocols. The third root cause analysis that was identified during this whole QI project was patient-related factors, which I thought was very interesting. It included the immunocompromised and multiple comorbidities that a patient may have coming into our surgical ICU. The environmental design, such as the ventilation system throughout the hospital, because it is an older hospital. This year actually made the 65th anniversary. And equipment maintenance and supply availability issues. For instance, our equipment availability, like our ECOS machine, it's down in central supply, or our ventilators, they're down in central supply, so we would have to go get them. So it's in transporting and everything, you come across germs. So there's a lack of cleaning technique because of the lack of availability per some of the nurses. Some national quality indicators that I found was that the Centers for Medicare and Medicaid Services stated that hospitals with a total HAC score greater than the 75th percentile of all HAC scores will receive a 1% payment reduction, which is huge for a hospital because that's Medicaid and Medicare's, they reimburse the hospital for stuff like this. The Joint Commission stated that one of the national patient safety goals is to comply with the CDC hand hygiene guidelines and or the current World Health Organization hand hygiene guidelines. The National Healthcare Safety Network also standardizes infection ratios for benchmarking. So to break that down, that just means that all of the reported data from any healthcare associated infection gets reported to the Joint Commission, CDC, and the National Health Work Safety Network. And all of that is tied into reimbursements of the hospital. My complete aim throughout this entire project was that within 6 months of implementing the initial health associated risk score, that there would be a reduction of healthcare associated infection rates in our surgical ICU, which is a 15-bed intensive care unit. And it would decrease by 50% with 0 central line associated infections per 1,000 patient days, and a 40% reduction in catheter associated infection. And this was all to improve patient safety outcomes and reduce healthcare costs for surgical intensive care patients and families and even staff members. So the process measures throughout this whole project was to ultimately decrease the number of HAIs in the SICU. The initial HAI risk assessment scoring requires the monitoring of the percentage of patients receiving the initial HAI risk assessment within the first 24 hours of the SICU admission or during the first encounter at the emergency department. So that just means that if for a newly admitted patient, they would go through a scoring of tracking the percentage identified and flagged for an enhanced risk assessment. And it will verify that whether the patient needs a heightened surveillance for this stay, specifically for the higher risk population. So the expected outcomes from initiating the initial HAI risk assessment scoring would be to decrease mortality and morbidity in all of our patient population, reduce an average length of stay, improve patient satisfaction, and enhance safety outcomes for our patients, because that is ultimately our number one goal. As far as the organization benefits, it would significantly reduce cost, improve the staff morale, enhance hospital reputation, and better regulatory compliance with the CDC, the Joint Commission, state. So basically, we would implement this strategy by implementing it within the first 24 hours of the SICU admission. The implementation strategy consists of 3 phases designed to ensure a comprehensive integration in the clinical workflows such as Epic. Phase 1 focuses on the risk assessment tool development. So it will incorporate validated risk factors, including patient demographics, such as age greater than 65 years or older, an immunocompromised status, surgical risk factors, including the procedure duration if it exceeded more than 4 hours, or an emergency surgery. A lot of our CABG patients exceed the 4 hours, so they would automatically be on a higher priority with this risk scoring. Some clinical indicators and presence of invasive devices, environmental factors such as any operating room traffic patterns and perioperative antibiotic timing, historical factors including a previous HAI history. If a patient is a readmit and they have had frequent healthcare associated infections, they would automatically be at the higher risk. For more surveillance, it will also include like a prolonged pre-surgical length of stay exceeding 72 hours. Phase 2 involves the integration into Epic, our electronic health record system. It involves embedding the HAI risk assessment into the admission workflow task. It will create automatic alerts for high-risk patients scoring 7 or greater out of 15 points. It will also establish a decision support tool that links risk scoring to specific evidence-based interventions, whether that be specific contact precautions, specific cleaning patterns, things like that. Phase 3 implements the intervention protocol with risk stratified approaches, where the lower risk patients scoring 0 to 3, patients receive the standard precautions with a daily reassessment, which would be integrated into the initial shift assessment that each day shift and night shift nurse is required to chart. The moderate risk patients scoring 4 to 6 points receive an enhanced surveillance with targeted interventions, and high risk patients scoring 7 or more points receive intensive monitoring protocols, including antimicrobial stewardship consultation within 12 hours, enhanced environmental cleaning protocols, like I mentioned earlier, specialized wound care consultation with our walk nurse, and daily multidisciplinary rounds focusing on device removal strategies. Because at this point in time, our intensivists only round on Monday and Thursdays. If we would implement this into rounding every day, Monday through Friday with the multidisciplinary team, we could definitely remove some of these unneeded devices that pose a infection threat to these patients. So this intervention of the initial assessment scoring, HIA risk assessment scoring, would benefit that rounding technique. The implementation follows a structured timeline where hours 0 to 12 on an admission assessment completion by receiving the nurse. Hours 2 and 4 will encompass a risk score calculation and documentation. And then hours 4 to 6 include a physician notification for any high-risk patients. And then hours 24 include the initial assessment effectiveness evaluation to ensure that all protocols are being adhered to and there's early prevention outcomes are being monitored. So again, the breakdown of how it would be in EPIC, it would be a flag scoring. 0 to 3 is your low risk, standard precautions for the patients. 4 to 6 is your moderate risk. That would be an enhanced surveillance. And then 7 or greater out of that 15 would require intensive monitoring, daily reassessments, antibiotic stewardships, a walk notification, just to ensure that this patient is adequately being monitored for these HIAs that are very preventable. So, with the implementation of this huge project, it would conclude a lot of our team members. We would have to have a lot of our team members on board for doing this. So our nursing leadership, that would include our CICU nurse manager, our clinical nurse educator, our 6 charge nurses, and our bedside nursing staff. Our medical team, our intensivist director, our medical director, our infectious disease specialist, and our other attending intensivist. Support services also plays a huge role in this. The infection control coordinator, IT systems analyst to help us implement this into EPIC, our quality improvement coordinator, and our pharmacist. Our pharmacist is a big factor in this, especially with antibiotics and right dosing and timing of them. And our executive leadership, they give the okay, the chief nursing officer and our chief medical officer. So there's always a catch-22. The financial impact. At first, the implementation cost is expensive, ranging about $192,000. And that would include education for our nursing staff, education for our attending staff, different education programs, the implementation of the new system into Epic as a whole. But our annual savings that would be able to prevent these HIA infections is huge. It would save us roughly $1.6 million, added up all of our patients that we see, and we get a total of, I would guess, at least 3 or 4 admissions a day. That's huge turnover, huge risk of infection giving to these patients and being readmitted and costing the hospital thousands of dollars. And not only that, costing these patients their lives too, when it can all be prevented. And through the annual savings, through this prevention, like I said, it reduces the length of stay. It reduces the decreased risk of readmissions. So the implementation timeline of this over a 12-month period. The pre-implementation phase spans weeks 1 through 4, beginning with literature review, completion, evidence synthesis, stakeholders identification, and initial engagement meetings, and a current assessment with the baseline data collection of our recent HIA scores during week 1. Week 2 focuses on the HIA risk assessment finalization, the integration of this risk assessment into our Epic system. This would include planning with the technical specialist, IT, and the training curriculum development for our staff and our doctors. Weeks 3 emphasizes the physician recruitment and education, nurse leadership engagement, workflow mapping, and the policy and procedure draft development. Because everything that we have to initiate has to have a policy. Weeks 4 involves just a pilot testing with 10 patient samples and any staff feedback collection and tool refinement, and a final protocol approval and sign off from our chief nursing officer or medical doctor officer. And then weeks 5 through 12, weeks 5 through 6 focus on the staff training rollout, and that would include scheduling for day shift and night shift nurses on days that can accommodate them to do this training. Then we would activate this system in our EHR. And testing and daily huddle integration with our staff. That includes night shift and day shift with enhanced communication, open feedback from our staff. That is a big key factor in making sure our QI project and implementation works. Weeks 7 and 8 involve a full implementation launch and a real-time monitoring and rapid cycle feedbacks from our staff and our doctors. This is supported by daily leadership rounds and staff support to address any immediate concerns. So again, still daily huddles, feedback from even patients and staff members. Weeks 11 and 12 focus on the initial outcome assessment and data analysis, feedback collection and process, standardization with comprehensive documentation. So basically weeks 11 and 12 just focuses on, okay, are we seeing an improvement? Are we seeing a change? Is this actually going to make a difference? And then weeks 17 through 20 involve the first quarterly review and process improvements. This again would be any expansion to planning into any additional units other than the SICU and the emergency department. Would it be on med-surg? Would it be on ortho? That could help decrease our HI scores in a whole for these patients as a hospital. And then we would establish a cost or benefit analysis to demonstrate the value and guide any future investments. And then weeks 21 through 26 include a 6-month outcome evaluation with long-term planning and best practice documentation that would support our hospital learning and replication. So with the implementation of an HI initial risk assessment scoring tool, we can thoroughly decrease the amount of healthcare associated infections that we bring upon our patients. This would help us keep track and really be more focused on making sure our patients are not only cared for but protected. Thank you.